So I'd like to thank the committee for selecting our abstract, which focuses on our work evaluating the role of transplant for patients that achieve a sustained remission following CD19 CAR T-cell therapy in our Seattle Children's Plateau 2 trial. Our CD19 CAR T-cell trial is a phase 1-2 study in pediatric and young adults with B-cell leukemia. The study objectives include determining manufacturing feasibility of the CAR product, as well as determining the safety of the product infusion, as well as the product's toxicity profile. On the phase 2 portion of the trial, we're additionally evaluating the efficacy of the product. The study's eligibility criteria include age greater than 12 months and less than 27 years, subjects with relapsed or refractory CD19 positive leukemia, subjects with a history of bone marrow transplant could not have active graft versus host disease, and subjects also needed an absolute lymphocyte count greater than 100 cells per microliter. We treated 43 subjects on the phase 1 portion of the trial, which has been previously described. 1 million CAR T cells per kilogram was determined to be the maximum tolerated dose, and this was the cell dose used for the phase 2 portion of the trial. The first 21 subjects treated on the phase 2 portion of the trial are described in abstract 4012. The 1-year leukemia-free survival for the subjects evaluated is 76%. However, we continue to see late relapses, including CD19 positive relapses at 22 and 27 months, as well as CD19 negative relapse at 37 and 41 months from CAR T-cell infusion. Therefore, we aim to evaluate the role of bone marrow transplant in maintaining leukemia-free survival and overall survival for subjects with sustained leukemic remission for greater than 63 days following CD19 CAR T-cell therapy. We retrospectively analyzed 50 subjects. 32 were treated on the phase 1 portion of the phase 1 dose-finding portion of the trial. The remaining 18 were treated on the initial phase 2 cohort. We excluded subjects who did not have an opportunity to undergo transplant. This included 4 subjects that did not respond to their CAR T cells, 9 that had an early relapse prior to day 63, and 1 subject that died from toxicity. We compared leukemia-free survival and overall survival between subjects with regards to the receipt of bone marrow transplant. When looking at leukemia-free survival for the subjects that did or did not receive a transplant appears to improve leukemia-free survival. We did not observe a difference in overall survival for the 2 groups, and we hypothesize this is due to continued responsiveness to therapy following post-CAR relapse, though more follow-up is needed. We then evaluated subjects without a history of transplant. It seems much of the transplant benefit observed on the previous graph stems from the population that received their first transplant. Here, the blue line represents subjects that received their first transplant following CAR therapy. The gray represents those that did not pursue a transplant. Of those subjects, 2 relapsed. Only 1 subject that received a transplant has relapsed. Though these numbers, there are a small number of subjects, the data is suggestive of a leukemia-free survival benefit for those without a history of transplant who pursue a transplant once in remission following CAR T-cell therapy. Again, we did not observe a difference in overall survival. Evaluating only the subjects with a history of transplant prior to CAR T-cell therapy, there does not appear to be a clear benefit to pursuing a transplant following CAR T-cells. The blue line above represents subjects that received a second transplant. Of the 10, 1 subject died from transplant complications and 4 subjects have relapsed. Of the 24 subjects that did not receive a transplant, 17 have relapsed. Overall survival between the 2 groups did not differ. Lastly, we evaluated only the subjects with short functional CD19 CAR T-cell persistence, demonstrated by return of CD19 positive cells by day 63 following cell infusion. Comparing subjects that did and did not receive a transplant, there appears to be a benefit to transplant for these subjects. As shown in gray, all subjects that did not receive a transplant ultimately experienced a relapse. Of the subjects that received a transplant, shown in blue, only 2 have relapsed. 1 subject died due to transplant complications following their second transplant. Again, here, overall survival was not statistically different. In conclusion, despite initial remissions, late leukemia relapse remains a barrier to long-term efficacy following CAR T-cell therapy for B-cell leukemia. Patients without a history of transplant who achieve a remission following CD19 CAR T-cell therapy may benefit from transplant. The role of transplant following CD19 CAR therapy for patients that have a history of transplant is unclear, and larger studies are needed. Transplant may abrogate the increased risk of relapse due to early loss of the CD19 CAR T-cell persistence. And overall survival differences were not observed, perhaps due to response to salvage therapy, though longer follow-up is needed.